These are scenarios in which muscle relaxation can worsen a patient's clinical status. If a patient has epiglottitis, muscle relaxants can cause complete airway obstruction and loss of ventilation. So in this case, if you need to induce anesthesia, you should induce with a volatile anesthetic with spontaneous respiration. In the case of a foreign body above the carina, paralysis can lead to complete airway obstruction, especially if the foreign body is at the level of the epiglottis. In patients with myotonic dystrophy, succinylcholine, which is used for paralysis, can lead to contractures of the airway muscles, making ventilation difficult or impossible. In patients with a tracheoesophageal fistula, positive pressure ventilation after paralysis can lead to stomach insufflation and aspiration. In patients with a mediastinal obstructing mass, paralysis can allow the mass to completely obstruct the airway, making ventilation impossible. And lastly, in patients with a Fontan repair, for instance, if they're getting an emergency C-section, positive pressure ventilation can limit passive blood return, leading to cardiac arrest. So you want to think twice before using muscle relaxation in any of these cases.